Hello, everybody. Welcome to a new episode of the Dissenter. I'm your host, Ricardo Lopes, as always, and today we're joined by Dr. Jayashri Kulkarni. She's Professor of Psychiatry at the Monash University, who works in the area of women's mental health. She has written about premenstrual syndrome. She has used hormones to treat schizophrenia, bipolar disorder, and depression in women. She founded and heads the Monash Alfred Psychiatry Research Center. So, Dr. Kulkarni, welcome to the show. It's a pleasure to everyone.
Thank you very much for having me on your program, Ricardo.
Sure, the pleasure is mine. So let's start by talking a little bit about depression. So is it really true that women are more susceptible to it than men?
Unfortunately, yes. The worldwide data shows that the ratio of women to men experiencing depression is 2 to 1. So twice as many women worldwide experience depression and anxiety disorders in their lifetime. So I wish it was not the case, of course, but this is the facts that we cannot dispute.
Mm-hmm. But what are the main risk factors for depression? Also, because then we will probably get into where that difference between men and women comes from.
Sure. So it's a very complicated condition. Depression or anxiety disorders is not as simple as physical health conditions. So we conceptualize the cause of depression as having biological reasons, psychological reasons, and environmental or social reasons. So when we look at depression in women, we can understand that there is some biological factors. And again, my work has been looking at the hormone factors, and I'll come back to that. There are psychological factors, which is the way that women perceive stress and deal with stress. And then there are the environmental or social issues, such as discrepancies in power. So men and women are often not given the same amount of power by society, not the same levels of salaries, particularly violence against women. You know, domestic violence and interpersonal violence is a big issue. So these are sorts of environmental issues that impact on the psychology and the biology. When we look at the biology, there are certain times in a woman's life when she's more at risk of depression and anxiety. Some of this is, for example, in the post-childbirth time. We know about post-natal or post-childbirth delivery depression. We also know that at menopause, leading into middle age, that there's many more women who experience depression. So there are some biological factors and hormone factors and other factors that really do lead to this issue. And of course, with COVID worldwide, with the pandemic, we have seen that the figures have escalated and got worse for women who are now experiencing even more depression and anxiety disorders.
Mm-hmm. So, but what are the concrete biological differences when it comes, for example, to hormones? And I'm not sure if there's perhaps some differences in brain structures or something like that between men and women that explain these higher susceptibility to depression in women.
Sure. So, I mean, one of the factors when we look at the reproductive hormones, that's the gonadal hormones, we know that estrogen, for example, is a very good antidepressant or antipsychotic in the brain. It works on the neurochemicals, serotonin, dopamine, and other neurochemicals, and it helps to keep the brain and mental health in check. So when there are big shifts in the estrogen, particularly around the monthly cycles, so there are fluctuations in estrogen, and when the estrogen levels are low, there is an issue or a problem with the neurochemical pathways then creating the depressive structures in the depressive neurochemical environment in the brain, which then, if it leads, if it's left unchecked, leads to circuit differences, and then that can lead to structural differences. So it's a complex hormone, brain chemistry, brain circuitry issue. And in women, the up and down nature of the hormone fluctuations seems to be one of the risk factors. I mean, men also have brain estrogen. They have not as much as women, but they have brain estrogen. But it is not fluctuating in the course of the adult life. And then also with pregnancy, for example, there is a massive change in the brain chemistry, which sees a rapid rise in estrogen, but then there's a rapid fall as soon as the baby is born. So there are many things that are at play here in terms of the hormonal fluctuations and the feedback into the brain chemistry in women more than men.
Mm-hmm. I'm not sure if this makes sense, but could testosterone also play a role there? Because since it is much higher in men than women, could it be a protection against depression?
So it's very interesting that you raise that, because in fact, in some situations, testosterone is experimentally given at small doses for actually increasing aggression and increasing such things as muscle mass and metabolism activity and so on, which of course is the opposite to what happens in depression. But the other side of testosterone is that, in fact, in psychotic conditions like schizophrenia, more testosterone is bad. So the testosterone there has a psychosis effect, but it could have an antidepressant effect.
Right. That's very interesting. I mean, the way hormones influence different kinds of conditions and how perhaps they interact with one another in people, in men, women, and individuals. It's very interesting. So tell us more now about postnatal depression. So what happens there? Are there some sort of hormone imbalances or something like that that explain why women suffer from this condition?
Yes, so what happens in pregnancy is that there's big, massive hormone shifts. From the minute that the woman becomes pregnant, the developing fetus creates a whole cascade and change in a number of different hormones. And this, of course, is happening in the brain. So for a very long time, it's very important to remember that, people did not believe or understand that gonadal hormones or the estrogen, progesterone, testosterone hormones had anything to do in the brain. They thought it was, all that they did was help with reproduction and having babies. Mm-hmm. So lots of important neuroscience findings have occurred in the last 10 or 15 years, and we understand a lot more about this. So in pregnancy, there is a massive rise in estrogen and progesterone in the woman's brain. And that, in fact, actually leads, in many cases, to the woman describing very good mental health during the pregnancy when all these hormones are high. So you often hear that story that she felt physically, there's the nausea and all the problems of the first trimester. But once that settles, mental health-wise, many women say the second and third trimester, they felt better than they ever felt before. Then, with the delivery of the baby, there is a massive change that happens it starts to happen as soon as the baby is delivered. The hormones suddenly drop. So estrogen has been very high, and then suddenly that level drops. And we think in that drop that in the woman who develops depression, this sudden drop does not change the mechanism, the switch mechanism, so that she then has a usual brain chemistry. And this may be, in fact, why some women without that switch, and that is probably, again, I can talk about the neurochemistry here. It's very interesting. The allopregnanolone switch and the NMDA systems, different neurochemistry is altered. So this woman who doesn't have that switch will then develop the postnatal depression fairly quickly. The other hormone that is at play here is in order to feed the newborn, the mother has to produce milk. And to produce breast milk, there is another hormone called prolactin, which creates the breast milk. Now, this hormone also has an effect in the brain, and it can be very depressive in the brain. So we often see that in the women who might be a little bit depressed, if they breastfeed for a long, long time, they can get more depressed. So that's not an easy thing to say, because of course we know that the breast milk is better for the baby rather than bottle feeding, which has different complications for the baby. But this is you're weighing up what's good for the mother, what's good for the baby. And sometimes that's a very tricky balance. But these hormones are very potent. They're potent neurosteroids, and they have a lot of effects in all sorts of ways in terms of brain chemistry and brain circuitry, and then eventually brain structures.
Mm-hmm. So when studying, for example, why in certain periods of women's lives, and particularly now we're talking about pregnancy, why in certain phases certain hormones go up and others go down, and then in others the opposite occurs. Do you also look into, for example, evolutionary explanations for that, or is that something you're not particularly interested in?
I'm not particularly doing research in that area, but of course the whole area is very interesting. We can theorize, we don't have evidence, but we can theorize that there's a whole reason for the nurturing psychology, if you like. I talked about biological and psychological. The psychological factors for women dealing with stress is that they may become depressed as a result of the stress. They take it inwards because evolutionary wise, they are not the hunters. They were not the hunters. So again, if you stress a male in that evolutionary sense, he'll fight. He'll throw a spear, he will run after the animal, he'll kill it. That sort of basic primitive behavior is very different to the basic primitive behavior of the woman, who will hide, will take the stress inwards and protect her babies. There's a evolutionary more primitive brain responses to these sorts of stresses. Of course, this is not the whole picture, because in modern days, there are many different intellectual and other mechanisms that we can use to deal with stress. And so this is one of the things that, we can overcome these things because it is not all predestined as it was for our primitive ancestors.
Mm-hmm. Yes, I also asked you that because I'm not sure to what extent this is supported by the evidence or not, but I've heard some people hypothesizing that maybe postnatal depression is a mechanism that evolved because in our early evolutionary environments, perhaps it would be easier for women, if that were the case, for them to get rid of the baby if it had any sort of problem, any sort of health problem that would render it basically unable to survive.
Well, these are all speculations. Again, there's nothing particularly that we have data or experience to say this. And certainly everything that happened in the primitive brain is not set. Our brains are evolving also. If you think about it, we are programmed to look at screens now, and rather than reading big books, we prefer to watch the films, we watch the screens. That takes different visual processing mechanisms. So again, our brains change. The roles of women have changed. We are no longer just about having babies. So biology is not all the story, but we still have to take some notice of the fact that there are some biological issues. But in women, we also have the technology now to use hormones to help to shift some of the biology as well.
So, and talking about that, and particularly using hormones to shift some of the biology in the case of women, since it's women we're focusing on now, what happens after menopause? Does menopause have any important impact on women's mental well-being?
Absolutely, it does. And menopause is a long process. Everybody thinks the woman is reproductive one day and the next day she's not. It doesn't work like that. It's a 10-year transition. So it's over time. And every change is that the estrogen is dropping. And as we know, the estrogen is a good hormone in the brain. It's protective. It's got a lot of useful, good mental health stabilizing points. And so with menopause, with the estrogen dropping in particular, we do see this rapid increase in depression in middle-aged women. And of course, it also affects a number of body systems. For example, the joints, your shoulder joint, ankle joint, hip joint, that many women have pains and aches in these joints because estrogen is a very potent musculoskeletal protecting agent also. So that can be a troubling issue. Hot flushes, we know temperature regulation is another estrogen role, and progesterone too. So there are many body effects, but the important effects that we study is in the mental health. And again here, evolutionary wise, the lifespan was short for women, so they didn't spend much time after menopause. They were probably dead by the time they were in their 50s. Right. So they would have menopause and not much more life expected after that. Now, of course, with most women living to their 80s and beyond, there is a considerable amount of life that is spent post-reproduction age. So we have a real important job to make sure that we understand the roles of the hormones in mental health so that the woman can actually have a good quality of life for a long period of time. And that's where hormone treatments are very effective.
Mm-hmm. And those hormone treatments, we're talking here mostly about hormone replacement therapy, right?
Yes. Mm-hmm. Combinations of estrogen and progesterone usually, but sometimes people use a little bit of testosterone also.
Mm-hmm. And these hormones used to replace the ones that after menopause women lack, they help tackling those mental health issues?
Correct. That's exactly what our data has shown, and our clinical trials work has helped many women who had very significant depression, and they didn't respond to standard antidepressant treatment, but they did respond very well to HRT, hormone replacement therapies.
Mm-hmm. So let's get into some other conditions you also study. Are there any important sex differences in susceptibility to schizophrenia?
So this is a very interesting question, and from worldwide data and the data I collected in my earlier work, we found that across the lifespan, men and women equally suffer from schizophrenia. So there's a 1-to-1 ratio across the lifespan. But the difference is that men tend to present at a younger age for the first time with their psychotic episodes. So it's very common to see 16-year-old to 19 or 20-year-old boys or men presenting with first episode schizophrenia, whereas for women, there's more likely that they will be about 24 up to 30 years of age presenting for the first time with schizophrenia. So this is the gender difference. The second gender difference is that there is a peak of onset of schizophrenia in the middle-aged women. So between 42, 43, up to 50, there's a second peak. It's not as big. So the biggest group is still between 24 and 30, but there's a second peak for women, which there is not for men. So this is again a reason to think that the hormone depletion with menopause is causing the second peak. And if we take the that hypothesis that estrogen is good for the brain, is protective against schizophrenia, so that when there is less estrogen, the woman is more likely to develop psychosis. We may also say that the 16-year-old woman has higher levels of estrogen, being just immediately post puberty. And so this is protecting her from early onset of schizophrenia. It takes a while for the levels to drop enough that then she develops schizophrenia.
And these early onset schizophrenia that we see occurring in men more than women, does it have anything to do with testosterone or not?
Yes, again, that's the other part of the hypothesis, that in 15 or 16-year-old boys, there is a large amount of testosterone immediately after the beginning of puberty or just at puberty. And it's not just the testosterone, the whole gonadal hormone axis is high. So there is the precursors to the testosterone in the hormones of the pituitary and the hypothalamus, that all of it is high, and that this may again be part of the reason that boys are presenting at a younger age with the schizophrenia, because testosterone is the opposite to estrogen in the schizophrenia world.
Mm-hmm. Do we see any sex differences in terms of how schizophrenia gets manifested in men and women? Do we have anything like that?
So you mean the symptoms that they experience?
Yes, exactly.
Yeah. So again, what we find is that, and again, the debate is the symptom difference because of the gender, or is it because of the age of onset? So traditionally, when you look at somebody who has early schizophrenia, they are young. They are not as developed in a lot of the skills, relationship skills, work skills, education skills. You know, they're younger. So their form of psychosis is more varied. It's not as clear. By the time somebody becomes mature as an adult, they have a better education, relationship, descriptions, and their symptoms seem to be clearer. So one of the things that we notice is women present with much more delusional pictures, and not so much the thought disorder and other aspects, whereas it's the opposite in the young presentations.
Very interesting. And what about bipolar disorder? Is that a condition where we also find gender differences and perhaps some role played by sex hormones?
So again, it's not clear in bipolar disorder what the gender differences particularly are, because there is an equal distribution of true bipolar disorder, that's bipolar type 1 in both men and women. But there are some case stories of the fact that the women present more with the depressive themes or the depressed phase, whereas the men may present more with the manic phase. But I don't think the evidence is as clear for bipolar disorder. And certainly the complication here is that there is a condition called bipolar type 2. Now, bipolar type 2 is where there is depression, but the mania is not as high. You know, right. It's hypomanic or a little mania. That's why it's called type 2. And the issue here is that many women who have bipolar type 2 have a very awful history of trauma and violence, sexual abuse. These things are, you take the story and the patient will tell awful stories of what happened to her when she was a child and a young adolescent. So you have the role of trauma in this presentation, which is, again, a different issue and can be making this presentation quite varied.
So now more of a general question. Do sex hormones have an impact on cognition?
Yes, they do. And my colleague, Associate Professor Caroline Gurvich's work is all about the hormones and cognition. And again, we note that in women, for example, at different cycle phases in the reproductive woman, in the low estrogen phases, she is not as good at the verbal skills, at the speaking skills, but better at the visual skills, visual processing. In other words, she's more masculine. In the high estrogen phases, it is opposite. So she's much better with speaking skills, verbal fluency, and so on, and not as good in the mathematics, spatial, or visual skills. So we find that the gender differences, by and large, are that men are better at visuospatial tasks rather than the words, the verbal tasks.
So in that sense, since we get a clear connection between hormone levels and the presence of certain hormones and how cognition differs across several domains, I mean, that also shows a link between sex hormones and the kinds of gender differences we find on average in different cognitive domains, correct?
That's right, that's correct. But these are the, this is an average picture. And of course, there are many exceptions to the picture. There are some women who are fabulous with visuospatial skills, and some men who are fabulous, like yourself, with verbal skills. So, it's not easy to characterize this for all men and women.
Sure. I mean, I was just thinking perhaps maybe instead of thinking strictly in terms of sex differences, trying to say that perhaps there's a clear biological link between sex hormones and how our cognition works.
Yeah. Yes, it is, because again, these are brain hormones. They work in many parts of the brain, including emotional expression and feelings, including cognitive or higher thinking, abstract thinking, mathematical thinking, as well as, the reality testing in terms of psychosis symptoms. They work across the brain. There are receptors for estrogen, for example, all throughout the brain. So it has profound effects in many, many ways.
But I mean, since we have these cognitive effects by sex hormones, that's also an important point when it comes to understanding perhaps not only why we get certain sex differences when it comes to susceptibility to certain psychiatric conditions, but also explaining perhaps why certain individuals are more susceptible to them than others, because I would imagine that there are several different aspects of cognition that play a role in psychiatric conditions, correct?
Absolutely, you're correct. You're very correct. It is, again, a role of susceptibility and style. Of how do you deal with the stress, the threat, somebody coming to attack you? What is your style? How do you deal with that? How do you cope with emotional processing? How do you verbalize? Do you verbalize, or do you keep it bottled up? I mean, all these things have a different conglomeration of biological, psychological, environmental factors. In environmental, I include family. What were you taught? How were you taught to contain or to express emotions? There's learning, and environment comes into that as well.
Right.
Very complicated.
Yeah, I imagine. So we've already talked about menopause. What about the use of oral contraceptives? Since they also change hormone levels, what kind of impact do they have on women's mental health?
Yes, they have a lot. And again, the development of the oral contraceptive pill is very important for women to have control over their reproduction. This is a very significant advance for women's rights. So this was the first thing that in the 1960s, it was seen as a really important thing. It is still. However, you remember I said people had a difficulty understanding that the sex hormones could have an impact on mental health. So when the pill was developed, the oral contraceptive pill, the mental health aspects of the pill was not considered. It was really thought that estrogen is all about whether the woman ovulates and whether she can then conceive a baby and so on. So there was no consideration given to the measurement of mental health with the pill. Now, we've done work in that, and others have done the epidemiological studies. And what we're all saying is that certain types of pill, particularly the progesterone in the pill, can cause depression in vulnerable women. Not every woman, but in some women. We don't know why some women are more susceptible to the environmental or the effect of the pill, but they are, and they can develop depression by taking the pill and certain types of pill. We say the pill, it's more than, there's many, many types. So this is one of the things that we are trying to do now, is understand which are the pill types that are better for depression and which are the ones that actually create more depression. But it's something that, women should be aware of, and their health practitioners, when the health practitioner is prescribing the oral contraceptive pill, or the woman is taking this, she needs to be aware that if she suddenly or slowly develops depression and nothing else is wrong in her life, that it could actually be due to the pill. That's very important.
So there's that link between the pill and depression. But could it be the case also that oral contraceptives might improve women's mental well-being in certain ways, or not?
Yes, particularly in the woman who has that cyclical fluctuation of mental health because of the cyclical variations in estrogen in particular. If you flatten this with the hormones, if you just give the pill, it causes the cycle to disappear, then that can improve her mental health. But you have to choose the right pill, otherwise you can make the situation much worse.
So with all of what we talked about in mind, should psychiatrists care about gender differences when it comes to, for example, diagnosing conditions and treating conditions and things like that?
Absolutely. It's really imperative that we don't treat patients as if they're all the same. Everybody is an individual, and everybody has specific biological, psychological, and social aspects to why they are mentally unwell, and that will also guide what should be the treatment. And gender is a big part of that. So we need to be very careful in understanding the gender impact, and we should be designing treatments for the future that take that into account.
And when it comes to psychiatric research, do you think that people do a good job in terms of controlling for sex, or is that something people should be more careful about?
I think we're beginning to control for sex, but I think there needs to be a lot more. And hopefully in the next 5-10 years, we'll see a lot more of the gender issue being looked at in research.
But do we need more women as part of clinical trials or not?
Absolutely, we do. And again, some of the rules that are made for clinical trials now state that, in fact, there should be equal numbers of men and women in the trials. And of course, we make sure that the woman has adequate contraception, because the last thing you want is unknown pregnancy with the effects of a new drug, for example, on the fetus. But that is possible. Women can control their fertility. And so we take advantage of that to make sure that new trials contain equal numbers.
Yes, I also asked you that question, these questions focused on sex/gender. I mean, whatever way you want to think about it, because nowadays we have this sort of discourse where certain people tend to ignore the socio-cultural factors behind sex differences. Others want to ignore completely the biological differences, but particularly here in psychiatry, it seems that it's a place where it shows that people should pay attention to all of those factors when trying to understand not only gender differences in behavior, for example, but also in susceptibility to different psychiatric conditions.
Yes, I do think that having a holistic view of the individual is a much better way to understand this individual's experience of mental ill health and then inform a holistic treatment done in collaboration with the individual so that you have a much better outcome, that you can't just expect one size fits all when it comes to treatment.
Mm-hmm. So just one last question. With all of this in mind, I mean, the fact that we have not only gender, but also individual differences in hormone levels, and perhaps we also have genetic factors playing a role in different psychiatric conditions, and then we have personal experiences, psychological and social factors. Do you think that this would make a good case for a personalized medicine?
Absolutely. I think that personalized medicine or individualized, tailored medicine is a much, much better way to go. It respects the individual's own experiences. I think we have a lot to learn from each of our patients who are living with the condition. And I always find it's incredible, some of the resilience and some of the things that people have been able to learn about themselves and put into practice. Is really great to work with patients in a collaborative sense and understand and learn from them and have an individualized approach for each person. We will always do better in that way.
Mm-hmm. Very well. Okay, so just before we go, Dr. Kulkarni, would you like to tell people where they can find your work on the internet?
Sure. So if you would like to log into our website, it is www.maprc, M-A-P-R-C .org.au. So www.maprc.org.au. That would find our research.
Okay, great. So I will be leaving a link to that in the description box of the interview. And Dr. Kulkarni, it's been a real pleasure to talk to you. Thank you so much for taking the time to come on the show.
It's been my pleasure. Thank you very much, Ricardo, for having me. Thank you.
Hi guys, thank you for watching this interview until the end. If you like what I'm doing, please consider supporting the channel. It's thanks to people like you that it keeps running, so I will leave links in the description box for PayPal and Patreon. Any amount, even just $1 per month, would already be a great help. Otherwise, and if you like what I'm doing, please share the interview, leave a like, and hit the subscription button. This show is brought to you by Enlights Learning and Development Done Differently. Check their website at enlights.com. I would also like to give a huge thank you to my main patrons and supporters, Karen Litska and Blanchett Pereira Larson, Lau Guerrero, Francis Ford, Hans Frederick Sunda, Ricardo Vladimir, Craig Healy, Adam Castle, Olaf Alex, Jonathan Wiesel, Jacob Klinkby, Matthew Whittingbird, Arno Wolf, Tim Hollesy, Enrique Lenius, John Connors, Paulina Barron, Philip Force Connolly, Jerry Mueller, Herbert Gintis, Rutger Vos, Bo Weingard, Rebecca Newberger Goldstein, Dan Demetrio, Robert Windiger, Rui Inácio, Arthur Coe, Zup, Marco Neves, Colin Holbrook, Susan Pinker, Thomas Trumbull, Bernardo Seixas, Pablo Santurbano, Simon Columba, Jorge Pinha, Phil Kavanagh, Corey Clark, Mark Life, Roberto Inguanzo, Mikkel Stormir, Eric Neumann, Samuel Andreev, Tiago Nunes, Bernard Hugni, Alexander Dunbauer, Omari Hickson, Fergal Cusson, Evan Bodrenko, Al Herzog, Don Ross, Jonathan Librand, Oslam Bullitt, Nathan Nguyen, Stanton T, Samuel Correa, Eric Hines, Mark Smith, J.W., João Eira, Tom Hummel, David Sloan Wilson, Yacila Dez Araújo, Eden Solon, Romain Roach, Dmitry Grigoriev, Diego Londoño Correa, Tom Roth, Yannick Punter, Adana Rusmani, Charlotte Bliss, Nicole Barbaro, Adam Hunt, Pavel Ostaszewski, Nelek Bach, Catherine and Patrick Tobin, Al Ortiz, Guy Madison, Gary G. Elman, João Linhares, Lida Cosmides, Saima Afzal, Adrian Diegui, Nick Golden, Paulo Tolentino, João Barbosa, Jules Price, Edward Hall. My producers, Isar Webb, Jim Frank, Lucas Tafinia, Kian Gilligan, Luís Caetano, Tom Vanagdam, Curtis Dixon, João Linhares, Benedict Mueller, Vega Guidi, Sardas France, Nirban Balachandran, and my executive producers, Michelle Rugieski, Rosie, James Pratt, Matthew Lavender, and Sergio Quadriano. Thank you for all.